For giving me an opportunity to be here today. I'll be talking to you on management of corneal complications in uveitis. I do not have any financial interest to disclose. Come to the management of uveitis. In every case of uveitis, we try to find out the cause. Either they can have a causative agent or they can have associated systemic disease, or we treat them with non-specific treatment of intraocular inflammations with topical or systemic steroids or the immunosuppressive agents, and we manage the complications. Coming to the corneal complications, they can be either reversible or irreversible. They can associate a corneal surface abnormality in the form of dry eye, or peripheral ulcerative keratitis, or in chronic cases they can have band-shaped keratopathy, stomal keratitis. If the keratic precipitates are severe, if the endothelium is damaged, they can go for corneal decompensation. Coming to the ocular surface abnormality, it's a case of rheumatoid arthritis. They can have severe dry eye with the superficial punctate keratitis or the filamentary keratitis. These cases were managed with topical lubricants, and we need to treat the associated abnormalities, either the meibomian gland dysfunction or the trichiasis. Topical cyclosporin is used to control the inflammation. We need to treat the underlying systemic disease, and if mild to moderate cases, we can use a punctal plug to preserve the existing tears. Next, they can have epithelial abnormalities in the form of viral keratitis. This particular patient was managed with topical antiviral cycloplegic agents and lubricants, following which there was resolution of the epithelial lesion. The band-shaped keratopathy is hydroxyapatite deposition of calcium carbonate in the basement membrane of the epithelium or in the Bowman's layer in the anterior stroma. It commonly occurs in the interpapillary fissure, begins in the 3 and 9 o'clock meridians. They can have a clear area between the limbus and the band-shaped area. Patients can be asymptomatic or they can present with irritation, pain and epiphora. The slit lamp examination shows the clear holes corresponding to the passage of corneal nerves in the Bowman's membrane, classically described as a Swiss cheese pattern. It's seen in chronic uveitis or conditions associated with hypercalcemia or hypophosphatasia. If the patient presents with a decreased vision or the chronic irritation and pain, we treat them. The recommended method is a chelation with disodium ethylene diamine tetraacetic acid, commonly known as EDTA. Do it under topical anesthesia, and we remove the epithelium either by the blade or by the 20% absolute alcohol. Then EDTA is commercially available as 5% solution. You take the 1 ml of the solutions, add 4 ml diluents, then we get the 1%, which pastes on the lesions for about 5 minutes. Or if deeper lesions or frequent lesions, it can take longer time, can go up to 45 minutes also. Then subsequent scraping of the Bowman's membrane is sufficient to remove the calcium deposits. Once it is removed, we place the bandage contact lens or the pad and bandage is applied till the epithelium heals. Procedural, we manage them with topical antibiotics and cycloplegic agents. A 6-year-old child presented to us in the year 2006 with the complaints of redness and pain in the right eye. On ophthalmic evaluation, she diagnosed of iridocyclitis with secondary glaucoma in the right eye. Systemic evaluation diagnosed of a JRA, was started on systemic steroids and also on methotrexate. Once the inflammation is under control, the child underwent BSK removal with EDTA and the general anesthesia, following which a visual acuity is improved to 6/9 in that eye. Subsequently, the patient had recurrence of inflammation. In that case, in addition to methotrexate, the child was started on mycophenolate meftil as well. The child was doing well. In the year 2010, child developed a swelling of the joint suggestive of a systemic arthritis. At that point of time, methotrexate was continued, MMF was stopped. We put the child on biologicals such as injection infliximab. Infliximab was continued along with methotrexate. Subsequently, the patient developed recurrence of BSK, which was removed in the March 2011. So far, the child has received 9 injections of infliximab. At present, the visual acuity is 6/9 and N6 in the right eye. So, we need to control not only the inflammations but also the systemic activity. A Yet another case is a case of presumed ocular tuberculosis with a floating harbor syndrome. The child had flat tip of nose, low posterior airline, and anterior rotation of the ears, has a band-shaped keratopathy and the complicated cataract in the left eye. Ultrasound B scan revealed the presence of disc drusen in both eyes with a normal posterior segment. Child was investigated, diagnosed to have ocular tuberculosis, was started on ATT and systemic steroids. Once the inflammation is under control, underwent BSK removal using EDTA. Visual acuity is improved to 612 in that eye. Here is a case of peripheral ulcerative keratitis, which was discussed by Somshila. So here is a 26 years female presented with recurrent redness in both eyes and treated as allergic conjunctivitis elsewhere. On evaluation, patient had scleritis with peripheral ulcerative keratitis. Systemic evaluation had right maxillary sinusitis with a positive C-ANCA. This patient was treated with IV methylprednisolone along with IV cyclophosphamide therapy. Following the infusion, one infusion, you could see the resolution of the lesions in both eyes. So rheumatoid arthritis, who had peripheral ulcerative keratitis with scleritis, responded well to systemic steroids and systemic immunosuppressive therapy. A 48-year female patient presented with 5 years history of rheumatoid arthritis with severe dry eye, not on any treatment. She developed a corneal melt under cover of systemic steroids and immunosuppressions, underwent a corneal patch graft. A 32-year male presented with recurrent redness in the right eye, responded to topical steroids. On investigation, had a positive MAN2. Quantiferon TB gold test was also positive. Treated with systemic and antituberculous drugs along with topical steroids. Almost following 11 months, you could see the resolution of the lesions in the right eye. The viral uveitis, here they can have a characteristic fine diffuse keratic precipitates, can damage the endothelium, or they can have a corneal scars. Extreme cases can associated with endothelial decompensation with the corneal edema. These patients are managed with topical steroids, cycloplegic agents, and systemic oral antiviral agents. Here is a middle-aged man diagnosed of herpes zoster ophthalmic with Sclerokeratouveitis, responded well to systemic steroids and systemic antiviral therapy. Sclero Uveitis due to Hansen's disease, it's more common in a country. Patients can have Sclero Uveitis with the flat tip of the nose and ear lobule. The skin biopsy showed the presence of lepra bacilli. Following anti-leprosy and systemic steroids, there was a resolution of the lesions, and more importantly, we can treat the infection, and subsequently the patient can present with recurrent uveitis due to immune-mediated reaction. In addition to that, due to the corneal anesthesia, they can develop complications in the post-treatment period, like exposure keratopathy. So we need to keep the corneal anesthesia in mind and manage these cases. It's a case of sarcoidosis with association with ICE syndrome, had a corneal decompensation, underwent a corneal graft. The graft failure was seen. At this point of time, under systemic steroids and topical steroid therapy, the patient underwent a penetrating keratoplasty, full thickness penetrating keratoplasty, following which his vision is improved. And subsequently, after 2 years, the graft started failing, which was managed with systemic and topical steroid therapy. Here is a case of a wasp injury. They are known to cause the corneal opacification and also the endothelial decompensation. They can have atrophic patches on the iris, associated secondary glaucoma, and the poor vision due to the optic atrophy. The next comes the amniotic membrane transplantation, useful in a case of chemical or thermal injuries or the corneal perforation or Stevens-Johnson syndrome. Here is a case of acid injury which was managed with amniotic membrane grafting. case of ocular surface abnormality with the limbal stem cells are managed with amniotic membrane with culture stem cells placed over the cornea. Once epithelialization occurs, subsequently you can do a penetrating keratoplasty for the visual rehabilitation. In rare instances, to rehabilitate the patient in a severe cases, we can do a keratoprosthesis which gives us ambulatory vision. However, it is not the recommended procedure in a case of inflamed eyes. Coming to the keratic precipitates, we have done the study using the confocal microscopy and we have classified the central globular with dendritic and infiltrative pattern of keratic precipitates are seen in infectious form of uveitis. This pattern is changed into pigment clumps following treatment. In extensive cases, causes irreversible damage of the cornea. To conclude, corneal complications of uveitis can be prevented with aggressive uveitis therapy. If corneal complications occurs, appropriate treatment can help to preserve good vision in these patients. Thank you for your attention.
Thank you very much, Dr.
Thank you.